thank you for coming this evening. So we're going to continue our Basics of ED sort of series with endocrine and metabolic emergencies today. I don't have my camera on because I'm on Outlook and it's really bad Wi-Fi. But if you do want to ask any questions, feel free to pop it in the chat or just unmute yourself and you're free to do so. Great. So yes, this is being recorded and you will get the slides as well. James will hopefully send that all out after. Okay, and like any other of these lectures you go to, it's not a full sort of, we're not going to cover all endocrine and metabolic emergencies. It has been reviewed by the Society and myself as well. But if you spot anything that you think maybe not quite right, just let me know. Okay, so that's what we're going to go through today. And again, in like the briefest detail. So adrenal crisis, DKA, hypoglycemia, hypo and hypothyroidism, and a couple of the electrolyte emergencies as well. So if we start off with adrenal crisis, so just to brief sort of talk about what adrenal hormones are and what can go wrong. So I've no doubt you guys have seen this before. So this is the HPA axis, and this is the mechanism by sort of how we produce cortisol from the adrenal gland. And cortisol, as you very well know, has lots of actions in the body. Anti-stress pathways, anti-inflammatory pathways, repairing of tissues, and providing our cells with glucose. But in some people, the adrenal glands can be destroyed, and most commonly this is through an autoimmune response. So this means they're not really able to sort of control their own cortisol, so they're quite deficient in this and they need replacement. So this is what's called Addison's disease, or previously known as primary adrenal insufficiency. So it's most common between ages of sort of 30, 50, and more common in females as well. And the sort of symptoms, you can kind of figure it out. If you don't have cortisol, you're going to lack energy because of the glucose deficiency that you're going to have. You're going to get some muscle weakness, low mood, loss of appetite, and weight loss as well. And the treatment to that is quite simple. So you just replace the hydrocortisone. That's the most similar drug that we have that sort of matches cortisol's actions. And we can also use Pred and Dex as well, but that's less commonly used. It's mostly hydrocortisone that we use for replacement. Okay, so just move straight on to adrenal crisis. So this is going to be all about the emergencies sort of side of things. So this is like a medical emergency, and it happens when the level of cortisol in the body falls quite significantly. So if a patient is even suspected at having an adrenal crisis, you have to treat them first. Giving the patient a hydrocortisone bolus is better than not giving them one, even if they're not in an adrenal crisis. So you're better off giving it rather than not. And sort of the treatment is quite similar as how we would manage just Addison's disease. So hydrocortisone, and they will be really dehydrated. So they may need rehydration with some IV fluids. That can be bolus or it can be maintenance, just depending on how they're presenting. Most commonly at least one bolus. Okay, so that's the first emergency. So we move swiftly on to type 1 diabetes. And again, just a bit of background on it first of all. So again, it's an autoimmune disorder. So in this instance, it's the pancreas that's attacked by your body's own immune system. And that leads to sort of reduced or no insulin production by the pancreas. And this, if it's undiagnosed or not treated correctly, or the patient's not compliant with their medication, it's going to lead to DKA. And so DKA is the sort of emergency type of type 1 diabetes. So again, this is when the body's insulin supply is significantly low. So the body has to try and sort of get its energy from somewhere else. And DKA can be like a complication of the patient who already has type 1 diabetes. So maybe they've forgotten to take the insulin, they've took the wrong dose, etc. Or it could be like a first presentation of type 1 diabetes. So they may not know that they have that. Other things can also sort of bring on DKA in patients who are type 1 diabetic, like an infection. So it's important to just sort of rule things out. So an intercurrent illness could sort of precipitate DKA as well. And so I mentioned the body has to sort of get its energy from somewhere else, and so it uses fat instead. And as it breaks down the fats to use for energy, this produces ketones. And obviously that's one of our markers of DKA. And you can test this either by urine, dip, or just a blood test. So these are the DKA symptoms. So you'll find the patient sort of finding it hard to breathe. The ketones give their breath like a fruity smelling breath. They'll have like other generalized symptoms like nausea, vomiting, muscle stiffness, just feeling fatigued and not themselves. So again, DKA obviously an emergency, so it needs to be treated correctly, diagnosed correctly. Obviously, in all these emergencies, the worst, absolutely worst thing that can happen is the patient could go into a coma and lead to death. That's like the extreme thing, but we're trying to diagnose it earlier and treat it earlier. So in DKA, there are 3 parameters that we use to diagnose DKA. So the first one, the patient is either known diabetic, or sort of when you take their blood glucose, it's more than 11. That's one of the parameters. Presence of ketones, so like I said, it can be like on a dipstick, or it can be sort of via blood test. And sort of the acidosis part of it, so the venous pH is less than 7.3, or the bicarb is low as well, so it's making them acidotic. So those are the sort of parameters that we would use to diagnose DKA. And then again, for the treatment, they will need a fluid bolus, so they're normally very dehydrated, losing a lot of fluids. But in this case, it's normally in the form of just an intravenous infusion rather than a bolus. And you also need to sort of treat the DKA itself, and you do that by giving a fixed rate insulin. So it is like a specified dose that you give, so it's 0.1 units per kg every hour. And if the glucose is dropping, you don't go, oh, okay, they're out of DKA now, stop the insulin. You don't stop the insulin, instead you just give them glucose, because they will need that insulin to sort of prevent them slipping back into DKA. And if they're on any long-acting insulin, so if they're known type 1 diabetic, you continue the long-acting, just stop like the rapid bolus. So if they're on like Nova Rapid, Actra Rapid, stop that. And with DKA, there could be quite a high chance of electrolyte abnormalities. So their potassium sort of can go a bit loopy. So just keeping an eye on that, normally via VBG. They may need some ABGs as well. We're just keeping an eye on the potassium, see what it's doing. Okay, so that is DKA. Does anyone have any questions so far? Feel free to sort of post on the chat or just use your mics. If not, we'll just carry on. So we're on to hypoglycemia now. So hypoglycemia, it's normally comes on in diabetic patients. So you can imagine some sort of scenario. The patient's in hospital, they're taking insulin, they've had a meal brought to them, but they've not really felt like eating it. Nurses have come and sort of given them insulin, or they're on a sulfonylurea or something like that, and their blood glucose just goes really low. So that's sort of typical situation where you might find it in like a hospital scenario. It can also happen in non-diabetics, but again, it's most commonly in diabetic patients that sort of happens. And there are 3 different severities of hypoglycemia, and there's different treatment for each kind. So we'll go through that. So there's mild, moderate, and severe hypoglycemia. So in mild hypoglycemia, the patient is still quite conscious, aware of what's going on, and they're able to swallow. In moderate, the patient is still conscious and able to swallow, but they're quite confused or might be a bit disorientated or aggressive or a bit of change in behaviour. So that's moderate hypoglycemia. In severe, the patient will now be unconscious, or if they're conscious, they'll be really aggressive. Yeah, and in all of these cases, obviously, you'd have to stop the IV insulin. So if they are on any IV insulin, obviously we don't want to be giving them any, if they're due their next dose of subcut insulin, sort of crossing that out of the drug chart. in the severe category as well, their blood glucose will be less than 2.6. So depending on sort of where they are at that point, there'll be different treatments for each. So in mild, we normally give like fast-acting carbohydrates like glucose juice, fruit juice, dextrose tablet. So you can see on the side here, this is the Lift like fast-acting glucose shot. So because they're conscious, able to swallow, we can give sort of that to bring it up a bit, and it's only mild hypoglycemia, so that will do. In moderate, we can do the same as above if the patient is, I was going to say, cooperative. And you can also use glucose gel as well. So it comes in a little sachet, and you sort of put it in the mouth, and that can help with the hypoglycemia as well. In severe, obviously if they're unconscious and they're not able to swallow, then if they do have IV access, then you can give them some dextrose IV. So it's normally 20%, 100 mils in 15 minutes. So it's kind of like a bolus. If they don't have any IV access, you can consider IM glucagon. If they're relatively quick to get IV access, you can do that, but sort of don't delay putting the cannula in, because the hypoglycemia would kill them first. So it just depends if they have IV access or not. And you're also escalating to senior in severe cases, so you're not going to be dealing with this on your own. You're going to be calling for help and advice from your senior. And this is really sort of a common question in PSA as well, for those of you who haven't done it yet. So there'll be a situation with a patient, they'll tell you if they're conscious or unconscious, if they have an IV cannula in or not, and then you sort of select the correct treatment that you want to give. So it does come up in med schools exams as well. And I thought I'd just put this in here because I find it quite useful. So that's the UHL logarithm for hypoglycemia. And it's quite good, as in you just choose sort of where they are on the hypoglycemia scale, and then it gives you different management options, and tells you what to do if it's not working, or sort of where to go on next, and what to do with the insulin, etc. So that's really useful. So I just thought I'd put that there if you guys want to look through that later on when you get the slides. Okay, any questions about DK or anything? Again, just pop it in the chat. Okay, so we move on to thyroid hormones. So you guys probably know what thyroid does in the body. So it increases our metabolic rate, it helps us with heat production, stimulates a lot of enzymes around the body, helps with lipid and carbohydrate metabolism, helps with obviously our heart rate, vasodilation. So it has a lot of actions in the body. So you can imagine the sort of symptoms that you would get when things go wrong. So in hyperthyroidism, you have overproduction of these thyroid hormones, so T4 and T3. And the most commonest cause is Graves' disease. So that's an autoimmune disease where you have receptors to the TSH receptor, or antibodies to the TSH receptor, and it continuously sort of stimulates the receptor, causing the thyroid to make more thyroid hormones. There are other causes. They're quite less common. So you can get sort of toxic nodules in your thyroid, which sort of overproduce the hormone. Certain drugs like amiodarone, as well, they can cause either hyper or hypothyroidism. So important to keep that in mind. And in the extreme case, it could be like a thyroid carcinoma. So you can sort of guess what the symptoms may be of hypothyroidism. Weight loss, heat intolerance, you've got overproduction of that, of all the thyroid hormones, you're feeling fatigued, sweaty, your heart's being sort of overstimulated, so you get tachycardia. And for the treatment, normally you use antithyroid drugs, so the carbimazole, and that sort of blocks formation of your thyroid hormones in your thyroid gland, by blocking sort of the enzymes like thyroid peroxidase enzyme. So your thyroid isn't able to make the thyroid hormone or couple them or iodinate them. And so you get a reduction in those thyroid hormones. So when we talk about thyrotoxic crisis, this is quite a rare complication of hypothyroidism. So this is a medical emergency, obviously, because it's a medical emergency talk. And it can be life-threatening as well, as with all emergencies. So thyrotoxic crisis happens when the thyroid gland releases quite a large amount of hormone in a short period of time. And the symptoms for that, obviously, you can just imagine just like a really bad hypothyroidism. So you get pyrexia, tachycardia, sort of liver dysfunction, organ dysfunction. And the treatment of thyroid storm is supportive measures, so IV fluids if they're sort of fluid depleted, oxygen if they're sat so low, cooling blankets because obviously they were pyrexic, and sweating, and also specific measures to treat the actual hypothyroidism itself. And after you've sort of done the sort of supportive measures, then a beta blocker is recommended to be started for anyone who has a suspected thyrotoxic crisis, just to help with that sort of tachycardia and just to calm the heart down a bit. Okay, so that was the emergency for hyperthyroidism. So we're going to hypothyroidism now. So it's basically the opposite. So if you have less or no thyroid hormone being produced, your symptoms are going to be opposite as well. So in terms of causes, we have Hashimoto's hypothyroidism. So again, that's an autoimmune disorder, and it sort of blocks the TPO enzyme that normally makes the thyroid hormone, and that's sort of stopped by the antibodies that you have, and so you make less thyroid hormone. Again, like I said, medications like amiodarone could go either way, and obviously damage caused if there's any like previous cancer and you've had an operation on your thyroid gland, or if you had like radioactive iodine for hypothyroid treatments, that can cause you to go into hypothyroidism as well. So it can be iatrogenic. In terms of symptoms, again, opposite. So you get cold intolerance, you get weight gain instead of weight loss. You still get like the tiredness and fatigue. They'll also get like constipation and muscle aches as well. So in terms of treatment, it's quite simple. You just replace the hormone. So medication like levothyroxine. In pregnancy, you'd give propylthiouracil, which is another medication. So it's just basically replacing the hormone that you've lost. So when things go wrong, when we get severe hypothyroidism, we get something called mixed edema coma, and it's quite rare again. It's usually in the elderly and those with sort of untreated hypothyroidism. It usually occurs in the winter for some reason. Symptoms, again, just like a bad version of hypothyroidism. So you get the hypothermia, bradycardia, you get sort of swelling and hypertension as well. Some patients can also get pericardial effusion around their heart. It's quite high mortality ratio, so it does require quite high dependency care. So you may have to escalate to sort of HDU or ITU for advice about accepting the patient. And in terms of treatment, they will need IV thyroxine, and also supportive treatment like warming the patient up, if they're hypertensive, giving them fluids, etc. Okay, so we'll move on to potassium. So potassium, again, a lot of roles in the body, is one of the main electrolytes that we have, and a lot of us have learned, I think, enough about potassium, but let's go through it again. So normal blood level around 3.5 to 5.3 helps to maintain sort of the normal fluid inside the cells, so it controls sort of fluid transport. Helps with muscle contraction, blood pressure. The most important thing it does is helps to trigger action potentials in the heart, so in the myocardial cells, and sort of activates the cells to sort of beat and contract normally. So you can imagine it's not that great for the heart when you have less potassium. So in terms of symptoms, it is sort of like a systemic symptoms that we get. So it would be fatigue, constipation, again, like we said, with the cardiac arrhythmias as well, and hypertension. So there are a lot of causes, but just to sort of name a couple. So vomiting and diarrhea. So if you're losing sort of potassium, same with laxatives as well. Alpha blockers can cause reduction in potassium. If you have something called refeeding syndrome, Con syndrome, and sort of certain diuretics as well, like potassium sparing diuretics like spironolactone, that can also reduce the potassium. So in terms of ECG changes, so everyone who has like any suspicion of sort of potassium deficiency or even hyperkalemia, they will need an ECG to see what their heart's doing. So in terms of hyperkalemia ECG changes, we get the small T wave, so you can see it sort of in the first image, and we get this U wave after the T wave as well, and we get an increased PR interval. So if you see an ECG that looks roughly like that, you can correlate it with sort of the patient's blood test, or investigate further. In terms of treatment, again, quite simple, just replace the potassium. If there are any sort of underlying causes, so if they are vomiting, if they are hypokalemic because of diuretics, then obviously you can sort of stop that and, treat the underlying cause instead of just giving them potassium and not solving the underlying reason. You can also replace magnesium, so low magnesium can lead to potassium secretion out of the body. So important to make sure that the magnesium levels are good. So when you're replacing the potassium, you're not sort of replacing it for no reason, because you need the magnesium level to be at a good level as well. In the extreme case, you can give IV potassium replacement as well, but that's always with sort of sodium chloride, so you don't give it on its own. And there's a maximum rate at which you can give IV potassium as well. So hyperkalemia, so this is the other way now. So again, a lot of causes, specific drugs, Addison's disease. If you have tumor lysis syndrome, those of you in 4th year might be learning about that at the moment. And again, we get different ECG changes with hyperkalemia. So we get these tented T waves. We get the prolonged QRS. The ST segment is sort of slurred up. We may get loss of P waves, or in the extreme case, we can get asystole as well. And with the hyperkalemia, it's obviously a bit more complicated than just because in hypokalemia, you just replace it. And there's a couple of things to do. So first of all, to stabilize the myocardium to prevent arrhythmias, and for that we give calcium gluconate, and that's just 10 mils of 10% over 10 minutes. So it's easy to remember. So that's just to, again, like I said, prevent any arrhythmias occurring, to stabilize the heart. So that's one problem. We also need to shift potassium back into the cells, and for that we give ActiRapid. So insulin sort of puts potassium back into the cells. That's why in DKA, when you're giving patients insulin infusions, their potassium can go a bit off, and that's why you check the potassium regularly. So if you're giving them ActiRapid in this case, you also need to give glucose, because that's going to make their glucose go low. Or instead of ActiRapid glucose, you can give salbutamol via nebulizer, but I've seen that less commonly done. People prefer to go for the ActiRapid and glucose first. Other thing we can do is eliminate potassium from the body. So things like calcium resonium, furosemide, dialysis. Again, dialysis is like the sort of last resort if your treatment above is ineffective. But things like calcium resonium, that can help to eliminate potassium from the body. Okay, so we move on to calcium. Again, another electrolyte involved in a lot of processes in the body. Normal levels are a bit lower, so 2.2, 2.6, and has a lot of roles. So roles in clotting, muscle contraction, again with heart rhythms as well. So hypocalcemia, so the symptoms normally occur at levels less than 1.9. And the commonest cause for this is after a thyroidectomy. So if you've had your thyroid removed, they may have accidentally caused removal or damage to parathyroid glands, and obviously they control the calcium levels. So if they're not able to sort of produce parathyroid hormone, your calcium levels may reduce. Vitamin D deficiency as well, that can cause hypocalcemia. And in this case, if you have vitamin D deficiency, you may also have low phosphate. Hypomagnesemia again, so important to check magnesium, because that can cause hypoparathyroidism, which obviously is low calcium as well. So a couple of causes to be aware of. Okay, so in terms of symptoms of hypercalcemia, slides are moving. Is the slides moving for people?
Yeah, sorry. It's still on hyperkalemia treatment for me. And I just wanted to check if it was only me or if it was everyone.
Okay. Is it moving for others or on hypercalcemia? Yeah, I think it might be just you, Han.
Yeah, that's fine. I'll just leave and come back. Okay.
Okay, cool. Yeah, do let me know if there's any issues with anyone else. Okay, so with hypercalcemia, so in terms of the symptoms, so we can get things like laryngospasm, prolonged QT interval and seizures, and that's what we call acute severe hypercalcemia, and that is our medical emergency in this case. But most commonly, it presents in a milder version. So things like muscle cramps, carpopedial spasm, which you can see in the top image there, perioral and peripheral paresthesia. And we have this thing called Chaucer's sign. And this is facial spasm when your cheek is tapped with a finger. So for some reason, we get twitching of the sort of facial muscles when you sort of tap your cheek with a finger in hypercalcemia, and Chaucer's sign as well. So this is sort of carpopedial spasm. So you're eliciting that sign when a blood pressure curve is inflated. And your carpopedial spasm is normally sort of adduction of your thumb, flexion of your wrist, and extension of the interphalangeal joints. So you can elicit those signs and sort of see if you think the patient has hypercalcemia, see if they have an acute severe version or if they just have the milder version. So in terms of hypercalcemia treatment, again, all with the low electrolytes, it's simple, you just replace it. So in this case, there's a little bit more to do, like more investigating to do. So treat the underlying cause, because we did mention on the previous slide that it can be because of low parathyroid hormones, it could be iatrogenic, it could be vitamin D, it could be magnesium. So we need to figure out sort of which of these it is so we know how to treat it properly. In the acute severe form, obviously we need to treat it right there and then. We don't have time to sort of investigate. And there you'll treat with IV calcium. But again, if it is vitamin D deficiency, then you give them a loading dose of cholecalciferol for a couple of weeks, and then you follow that by maintenance doses, so lower doses. If it's because of hyperparathyroidism, you treat it with calcitriol. You can also just give oral calcium supplements. So if the hypercalcemia is due to like a drug which they can't stop and they need it, you can just replace the calcium. And we want to aim for calcium levels at the lower end of the reference range, so 2.2, 2.3. We don't want to overload them with calcium because that can cause sort of other difficulties like stones in the kidney tubules, etc. So we want to sort of aim at the lower end. So if we go the other way, hypercalcemia, so that's when it's 2.6 or above. And the commonest causes here are primary hyperparathyroidism and malignancy. So it's quite important to know that in malignancy, you will have hypercalcemia and a low PTH. But in primary hyperparathyroidism, because the parathyroid gland is overactive, you'll have hypercalcemia with a raised PTH. So if you do see an isolated increased calcium, it's important to get a PTH level as well, to see if you're concerned or not concerned about malignancy. So like I said, if it's hypercalcemia with a low PTH, it's malignancy until proven otherwise. So it has to be excluded, and is usually associated with squamous cell tumours. And that's due to the release of PTH-related peptide by the tumour. And that causes stimulation of the parathyroid gland, and that causes your hypercalcemia. So it mainly occurs in the large or advanced tumours. Bony mets may not be present, and same occurs in TB and sarcoidosis. So in TB and sarcoidosis as well, you can get this hypercalcemia with a low PTH. So a little bit of investigating to do as to why they have hypercalcemia if they have a low PTH. So if they have a hypercalcemia with a raised PTH, it's primary hyperparathyroidism until proven otherwise. So if the PTH is like normal or the upper range, malignancy is unlikely in this case. And again, it's usually due to like a single adenoma in the parathyroid gland. And again, quite rare to have parathyroid cancer, but it is sort of more likely if your serum calcium is raised above 3.5. So again, that's another thing to be aware of. Not to completely rule out malignancy if you have hypercalcemia with raised PTH, which just keep that in the back of your mind. So again, with acute severe hypercalcemia, it may present as profound dehydration, renal impairment, and we do need urgent treatment for this, of course, as a medical emergency. And again, treating the underlying cause in the sort of long term as well. So in severe hypercalcemia, we're going to treat the dehydration, and we do this with 1 litre sodium chloride over 4 hours. We need to just stop any drugs that might be causing the hypercalcemia or making it worse, so thiazides, vitamin D compounds. We need to use bisphosphonates, and what that does is inhibits sort of calcium from mobilizing from the bones. So it helps to sort of try and reduce the calcium down. We can use calcitonin for treatment of hypercalcemia, not commonly used, but it's more used in hypercalcemia that's associated with malignancy. And again, finding out the underlying cause, what's happening here, what's the actual reason for the hypercalcemia, and how do we prevent it from happening again. So that's gone by really quickly, so 40 minutes. So these are all the references that I use. Endocrine can be, there's a lot of things to cover in endocrine, with all the different hormones and different levels and different treatments. But hopefully some of these sort of resources can help you sort of work through that. And thank you for turning up, guys. I'm glad it's ended a bit early, so you can go and sort of do what you want for the rest of the evening. If you do have any questions, my email address is on the slides. You will get the slides on the recording. But yeah, don't hesitate to email me. It doesn't have to be about endocrine, it can be about anything. If you do have any questions. Great, thank you guys.